welcome everyone, and I'm glad that there's some students here. In fact, I won't talk about my sort of obesity-related stuff much today, but we have had several students come over from DGHI and work with us in Singapore on various projects, and we certainly are excited when that happens. And so any of you students who might be interested, definitely let me know. So today I'm really going to wear my Lien Centre hat and talk a lot about our end-of-life research in Singapore and some of the education projects. And so feel free to stop me as we go along with questions. The general outline is I'll just give a brief presentation to the center and then talk quite a bit about one area of research that's my main interest as an economist, looking at really preferences and decision-making around end-of-life care. And in fact, people in Singapore seem to think that economists just care about cost and trying to get people to die as cheap as possible. We do think about that, but the reality is that's not so interesting to me. What I'm actually most interested in is understanding choice and behavior. And in fact, economics, for those of you who haven't been exposed to it, is really about choices under scarcity. So when you're constrained, how do you make choices? And in fact, it's certainly true that at the end of life is when some of the most difficult decisions are faced, as well as some of the most expensive decisions. And so people sometimes ask me, like, why are you as an economist thinking about running a center for palliative care? But if you think about it as choices under constraints, it makes sense. And you'll see as we go forward how we apply economic thinking and economic theory to look at decisions around end-of-life care. Okay, and then I'll talk a little bit about some of the other stuff that we're doing in research and a little bit on education. So that's the plan. I'm a little jet lagged, so bear with me. If I said anything too inappropriate, apologize. Okay, so here we go. So let me just tell you a little bit. So our goal is actually very modest, to be the premier palliative care research and education center in Singapore. Now I say modest because there's really only 2 in the region, and we just have to be better than the other guys. So we think we can do it. But the reality is people die horribly in Asia. Right? There's very little access to pain medicines. There's very little access to palliative care clinicians. And so our real goal is to improve the end-of-life experience for patients in the region, which is an ambitious goal and something that we think is super important. But we actually have really high aspirations and think we can meet those goals. Right? Now, on the research side, we just want to implement projects that we think really can move the needle, that can help us make that happen. And the truth is, our funding is largely Singapore-based, and funding is always a key consideration in where our research winds up. And so most of our research is Singapore-based, but we're increasingly looking to move out into the region and looking for funding sources to make that happen. I'll talk about one project that's quite exciting in that front. Now, I took over the center, I guess, about 4 or 5 years ago, and the truth is it was struggling a bit at that time, and we didn't have a very strong focus. So it wasn't clear what we were going to do. And in fact, the first thing I did was put together a strategic plan really to try to carve out what we would do. And so if you look at the areas, I said, all right, we're going to narrow our focus. We're not going to do drug studies, even though certainly you could. And we're going to really focus on 4 areas. One is my interest in understanding preferences and decision-making. The other one is end-of-life communication. So we have a health communication person with us, and in fact, we hired Kat Pollack, who is a Duke person here, who's point 2 in our center, and she works with some of our senior folks in communication strategies. Financing and delivery models, super important. The truth is we haven't done as much in that area as we could, but if you think about, I always think as an economist that form follows financing. So if you get the financing right, the form will follow. So if you think, for example, like way back, this is probably before lots of your time, but in 1985 when the US government instituted DRGs, which was really paying people instead of per diem costs or day rates for hospitals, they just paid fixed bundles. Within 5 years, you saw 1,000 hospitals merge or close, right? So lots of hospital consolidation. So I think if you get the financing right, you'll see good things happen. But the reality is the financing is horrible in Singapore. They really only pay for inpatient care, not for home hospice, not for inpatient hospice. And so people end up dying in the hospital, which is not what people would want. So we're looking at that area, and we're certainly looking a lot about how to improve pain and symptom management. Right? So those are some of the few areas. But let me just talk a little bit about our preference work. Okay. So here I'm going to talk about a study that we published a couple years ago, sort of our first big study looking at preferences in Singapore. We used something called a discrete choice experiment, which is a stated preference survey. And the idea behind the discrete choice is that if I ask you enough questions and I'm systematic about how I ask those questions, I can start to learn a lot about your preferences and what you think is important. So I want everybody to take 30 seconds and think to yourself, if you say had a life-limiting illness, say an advanced cancer, this is really the scenario we posed to people like you guys in Singapore. We said, okay, you could choose, and the rows here, by the way, were based on qualitative studies about what people claimed was important to them. We said, okay, suppose you could choose between scenario A, where you experience moderate pain, you're a burden on caregivers for about 3 days a week, your length of survival is 10 months, your quality of healthcare experience, how it's coordinated, are you treated with dignity and respect, is fairly poor. It's going to cost you $20,000. Now in Singapore, you can ignore this, I suppose, but in Singapore, everybody has a health savings account. It's mandatory. And so most healthcare is paid first out of your health savings account. Then you might have coverage through a high deductible health plan called MediShield, and then you would pay out of pocket. But most people would prefer to pay out of their MediSave than out of either their own or their family members out of pocket. And by the way, in Singapore, they have family-based risk pooling. So if I run out of money out of my own health savings account, I can pull from my parents, my siblings, or my kids. And in fact, it can be mandatory. So the government will force your kids, for example, to pay for you if you don't have enough in your own account. It's created some interesting family dynamics. In fact, some of my students say, like, they try to get their parents to quit smoking because they don't want to have to pay their medical bills. Okay, so scenario A is one I just read out. You end up with a home debt, which most people prefer. Scenario B has different levels of these attributes. So everybody take 30 seconds and think to yourself, would you choose scenario A or would you choose scenario B? Write it down. You got it? Okay, here's one more. Now, in our studies, we usually ask about 8 or 9 of these before we end up starting. We have enough information per person to model it. So, okay, so here, if you look closely, the scenarios differ. So I want everybody to do the same experiment. Think to yourself, would you choose scenario A or scenario B? Okay, so let's do a little test here. So raise your hand if you chose A in the first and A in the second. I see the old men. older.
No, you had it right.
Distinguished gentlemen. Okay. So, okay, hold on. So, who chose A in the first and B in the second? Okay, how about B and then B? How about B and then A? So, okay, so there's a couple of things that you notice here. So, right, so there's a lot of heterogeneity in the room. And in fact, that's certainly reasonable, right? I mean, people have different preferences. So somebody tell me, for example, did somebody focus very strongly on one thing that they thought was really important and just pick based on that? What did you choose?
Home.
Dying at home, important, right? Anybody else?
Pain.
Avoiding severe pain, right?
The quality of healthcare experience.
Quality of healthcare experience, okay.
Whether or not my family will be paying it for.
You didn't want
payment.
you did or do not want your,
No.
yeah, okay. You didn't want to screw them one last time.
At first it was home, but afterwards it was amount of care required from family and friends. So they can contribute to me and I can take care of myself most of the time, I think.
How about cost? Did anybody just say they want to die cheap?
Yeah.
Yeah. Okay. Well, you're not alone. So let me tell you. So we did this survey first among community-dwelling older adults in Singapore. And those of you who focus on just one thing very strongly, we call that sort of dominant, right? So there's a particular attribute that dominates your thinking. In fact, in Singapore, 40% of people had one thing that in every single question they chose the best, their favorite for that. Now, of course, it varied, but it turns out in Singapore, and if you know Singaporeans, you won't be surprised with they're very pragmatic people. They just said, I just want to die cheap. Or so they thought. And in fact, 22% of them just picked the lowest cost option in every one. Right? But other people traded off. And in fact, if you look at the data, let me show you sort of one way to interpret this data. So basically, these are called preference weights. And the weight, the length of the line tells you something about how important that attribute is relative to the other attributes. And higher is better. So what you see right away from looking at this is cost was very dominant in people's thinking. So it weighed very heavily in their choices. Now, you can also see there's a little bit of noise in the data, but avoiding severe pain, as at least one of you mentioned, is important. So people really don't want severe pain, but between mild, moderate, or no pain, it's not so obvious. Now, not wanting to be a burden on caregivers is something that we tend to find in all of our Singapore surveys. And I think it's because everybody in Singapore has a helper, so they don't really worry too much about that. So it's very common that you have a foreign domestic worker. So we didn't see a lot of it here. And in fact, what tends to happen in Singapore is the first time somebody gets sick in the household, they don't have one already, the family goes out and buys a helper. You can get a helper from the Philippines or Indonesia for $500 or $600 US a month. And it's by far the cheapest way to provide care. And in fact, if you look at the informal care system in Singapore, they deliver a lot of the care for seniors and end-of-life patients. It's just cheaper, right? And by the way, many of them do amazing work. Now, okay, survival, this is interesting as well. I mean, there's a little bit of a downturn here. Maybe if it's between 4 and 6 months, people are saying, might as well be 4. But then certainly as things improve, it's better. Higher is better. People like higher quality, but if it's too high, they might see it as excessive, so it drops down a little bit. And then, as I mentioned, cost is important, and people have a real ordering. They would prefer, and I think a few of you mentioned this, they prefer to pay out of their own MediSave account than a family's MediSave account. Cash is the worst, but really bad is having to use their family members' cash. Right? So that's not unintuitive. It makes sense, right? And people would prefer to die at home, right? Now, we can also use these results to look at willingness to pay, right? How much would people pay to move across the different levels of these attributes? And what we find is that the willingness to pay estimates, in general, are pretty low, right? So how do I know they're low? Well, in the US, I don't know if any of you have been exposed to cost effectiveness analysis, but people talk about a reasonable value for money would be paying $50,000 for an additional quality-adjusted life year gain, right? So these guys are saying they'd only pay $28.40 to get an additional life gain with cancer. Now, it's not a perfect life because they're certainly going to be ill, but $28.40 is a lot lower than $50,000, right? So I think it's important to see that these are pretty low values, but I think it's also important to see that extending life is by far lower on their list or not their highest priority compared to some of these other things. Certainly avoiding severe pain is really important. Now, why is that important? Well, to me, that's important because the healthcare system in Singapore, as well as just about every developed country in the world, focuses almost entirely on this and avoids quite a few of these other things. Certainly, you can easily do better at having people die at home. Opioids are cheap, but in Singapore, because they're so anti-drug, they tend not to even give dying patients morphine, right, for fear that they might get addicted, believe it or not. And so we're not very good at delivering on lots of these dimensions, despite the fact this is what people are telling us they want. But yet the healthcare system pushes survival, right? So I think that's important. But I think there's another issue that's challenging here. And so we asked you guys, or community dwelling older adults in Singapore, to tell us what they would want if they were diagnosed with advanced illness. And that's actually not an unreasonable question, because that's essentially what we're doing when we ask people to buy insurance, health insurance, life insurance, or when we ask people to fill out advanced directives or advanced care plans. We're saying, okay, thinking ahead to some state where you have illness, we want you to prepare accordingly and buy insurance or prepare these things. It's a tall order, and the question is, do we get it right? Right? Do we really know what we would do if we were faced with a life-limiting illness? Right? It's an important question. So I suspect the answer is probably not. Now, let me show you a video. Actually, I have to decide. I know the bottom one looks pretty enticing, but let me show you. Actually, the bottom one is an American one. But let me show you the top one, which is a Singapore one. Maybe I'll show you both.
How will the future you thank you? Get started with insurance and financial planning with NTUC Income. You won't want to look back and keep yourself.
You get it?
Yeah.
So I've seen that commercial dozens of times or more, because when you go to the movies in Singapore, it's on before every movie. So let me show this one real quick. This one, by the way, used to be my insurance company.
I am never getting married. Never. Guaranteed.
You picked a beautiful ring. Thank you. We're never having kids.
Over here.
We're never moving to the suburbs. We're never getting one of those. We're never having another kid.
I'm pregnant.
I'm never letting go.
For all the nevers in life, State Farm is there.
So why do insurance companies make commercials like this? What's the lesson?
You need to prepare, and they can help you, but don't expect it.
Yeah, but what else are they saying? Right? They're not only saying that we think you're going to get it wrong, but how do they think you're going to get it wrong?
Not being prepared.
In what way?
Having insurance.
Too little insurance, right? So insurance companies know that people are present biased, right? They don't save for a rainy day. They don't plan ahead for the future. And so NTUC insurance in Singapore, State Farm insurance in the US, I mean, the commercials are essentially identical, right? They're saying you're going to goof it. You're going to think too much about today, not enough about tomorrow, and there are real consequences of this, right? And so they're trying to educate you and say, plan for the future. Don't put yourself in that situation, right? So it turns out that they're onto something. And in fact, there's a fantastic paper, unfortunately I didn't publish it, but it's good anyway, in Science, called The End of History Illusion. I would encourage all of you to read this paper, it's great. But basically what the authors of this paper say is they say, look, as people go through life, no matter how old they are, if you ask people, have you changed a lot in the past? They will tell you, oh yeah, I've changed a lot. And they'll say, well, do you think you'll change in the future? Say, no. Now I know. Now I know my true self. And no matter how old people are or were in this manuscript, they asked them and they saw the exact same thing. So everybody seems to think that their current self knows what their future self will want, but they always get it wrong, right? So when you're asked to think about what you would do when faced with a life-limiting illness, you'll make some guesses, but you'll probably be wrong, right? So we looked at that, right? So we looked at that in this paper. So not only did we survey regular people like us, community-dwelling older adults, about their preferences, but we also looked at real patients, right? So we surveyed, and by the way, we have a really amazing team of data collectors that we send out into the hospital, and they do some pretty sensitive surveys. And it's not easy to ask dying cancer patients questions about how long they would live or all of these things, but they do it. and it allows us to learn a lot about people's preferences. And so one of the things we learned here is not surprisingly, real patients have a much higher willingness to pay than what we thought they would, right? By the way, when I got my dog many years ago, I could have bought the doggy insurance, and I said, forget it, it's just a dog. If he needs a major thing, we wouldn't do it. 4 years later, tore his ACL. It was a $4,000 surgery, and my kids were crying, my wife was crying. Sure enough, we got the dog the surgery. So I too got it wrong, right? So it can happen to the best of us. But the point is here, very different. Now, I will say, so our willingness to pay estimates are quite high, but I think there's also another implication. Even among late-stage cancer patients, you still see, increasing survival is not their biggest thing, right? They're still looking at place of death, avoiding severe pain, and even high-quality care, where they have high continuity treated with it. These things matter at least as much as extending survival. So again, I think these are strong implications that are quite important, right? Now, there is a second question. I think the way I just presented this, the idea is that patients know what they want. So I think that's a better assumption than when you say people like us know what we would want when these things happen. The problem is that patients are challenged as well, right? So I use this term right very loosely, but let me just give you some data. So these patients that we spoke with, they told us some things about their preferences, right? And they told us a lot about their trade-offs, right? But one of the questions I have is how informed are their responses and what are driving those decisions? And again, this is a pretty important question. So let me put a little context to this. So we have a cohort study I'll talk a little bit about sooner, but basically this is another very sensitive survey that we're fielding right now. We asked 484 patients at the largest cancer hospital in Singapore to tell us about their expected survival. Now, all of these patients are stage 4 cancer patients, and all of these patients are recruited into our study because their treating physician said they would be surprised if they lived more than a year. So this is a common question, the surprise question, where physicians, essentially you ask a physician, would you be surprised if this person lived more than 12 months? If the physician says yes, then things tend to happen, referrals to palliative care and other things. But in fact, that was the trigger that we used to get people into our study. So the expectation is that within 12 months, all of these patients are likely to pass, right? So we asked them some questions, but before we asked them some questions, we said, okay, how informed do you feel about the state of your illness? And in fact, 68% felt very informed that they understood what was happening to them. That's, I guess, pretty good news, right? Well, it turns out that among all of these patients that we would expect to pass within a year, 31% of them thinks their current treatments will cure them. That's bad. That's a major red flag, right? In fact, even worse is that although we think 100% will, the patients themselves, only 2% of them told us that they think they would live less than a year. In fact, 25% think they would live 10 years or more, right? Now, all of these things are troubling, but there's another troubling factor, and the reality is that patients' decision-making is influenced by lots of things. Some that it should, some that it shouldn't. And in fact, for example, if you look at our data, one of the things that we found that was very interesting is, all of these patients are stage 4. All of these patients will be expected to pass within 12 months. But if you looked at who was optimistic and who was less optimistic, it turned out if you were first diagnosed at stage 4, you were far more optimistic than if you were first diagnosed at stage 1. And the reality is, none of this should matter because all of them are stage 4. So why do you think it is that a stage 1 first diagnosis patient is going to be less optimistic than a stage 4 patient?
They've had more time to see their own decline.
Yeah, they've had not only more time to see it, but they've experienced a lot of treatment failure.
Prospect theory would suggest that if I've had a downside event it's come late, then I'm going to be risk seeking. I'm going to be optimistic. I'm going to say this new treatment is going to help me. I may be overly optimistic, whereas if I've been diagnosed earlier, I've expended that. I've seen that it hasn't. The progression of disease has continued, so it has defeated that overly optimistic response.
Could be. So we also have data on health-seeking behaviors for these patients. So we'll look at the extent to which past experience influences future health-seeking behaviors. I actually thought there might be a different story, that if you're first diagnosed at stage 1, you're told, oh, you're going to beat this thing, right? You're pretty optimistic, rightly so. And then you're the minority who goes on to stage 2, and then you're sort of told, well, okay, things don't look as good, but we think we can do something for you, and so on and so on. And the extent to which that people truly update their biases, right, or their priors, right? But it turns out here, those who were diagnosed early, this treatment failure or prospect is giving them very different perceptions on future success relative to other patients. So my only point is, you might think to yourself, the ideal scenario is that patients are making decisions for themselves. And my point is, well, patients are making decisions, maybe that sounds great, but when they're making decisions based on things that shouldn't matter, or based on very bad information, that too is problematic, right? So one of the things you might suggest is that maybe patients aren't best positioned to be making these decisions, right? And in fact, the reality is, in Singapore, caregivers tend to make a lot of the decisions. And in fact, it's not uncommon. So what I'm told is that about 25% of cancer patients at the biggest hospital in Singapore never are told that they have cancer. The caregiver will intervene and say, I'll talk to the physician. And in Asia, you can get away with this. And basically, the patient will even be sitting getting their chemotherapy drip in the cancer hospital and have no idea what they're doing and why they're there. Not uncommon, right? But how problematic is that? So we asked that question, and we looked at another study where we surveyed both patients and caregivers to get a sense of how different their preferences were, using essentially the same strategy. And so here are the results of that study. So this is just the same data that I showed you earlier, and the last column are the caregiver preferences here, right? Now, it turns out that the caregiver preferences are much, much higher, and in fact, remember I mentioned that $50,000 per quality adjusted life year gain? Well, now we're actually closer, okay? So here, we're 61, these are Singapore dollars, so it's pretty close. So if we're getting an extra year, instead of 17,000, it's 60,000. But even caregivers still would be willing to pay more for having patients die at home versus an institution and for avoiding severe pain. Now, fortunately, they were not so hung up on caregiver burden, which is nice, but certainly still willing to pay for quality. Now, when you look at these two columns, what do you see? What are the implications of this? Is this good or bad?
Well, if your goal is spending less money, it's not very good.
Well, what should your goal be?
Well,
I mean, what does it suggest about the extent to which caregivers are good surrogates?
There may be a bias where maybe they're willing to spend more than the patient is, or maybe they're willing to spend less on certain things. It's not taking the patient's ideals in mind as much.
Yeah, I mean, clearly not. I mean, I think the concern here is that patients are highly likely to be overtreated when it's left to the caregiver, right? I mean, what we hear is that caregivers don't want to leave anything on the table that they think might help, right? They don't want to experience regret. So patients are going to weigh the costs and benefits of various treatment options as well. Patients also care oftentimes about bequests, right? Caregivers may or may not care about those things, but they also care about perception. They don't want to be seen as not doing all they can for a loved one. They want this patient to be alive, not just for the patient, but also for them. So there's sort of an externality argument. But basically, overtreatment is highly common when the patient themselves is kept out of the loop. And so that's a major concern. Go ahead.
I agree with you. There's just, for me, very good care, quality of care, and over-treatment confound one another, because one definition of quality of care is they did everything they could for me in the mind of the patient and sometimes in the mind of the caregiver. So,
no, fair point. Although here, I didn't show you a lot of the details of this. We're very careful to define quality as unrelated to outcomes.
fair enough.
Yeah. But I think your
but they
point
still
is good.
tried everything, even if it didn't work.
Yeah, and in fact, we have a similar study looking at dialysis patients. And what we find is that caregivers want to give their loved one dialysis even if it has no health benefit.
Yeah.
So they just want to do something. Right? And in fact, in Singapore, so by the way, dialysis is great for younger, healthier patients, but if you're over age 75 with comorbidities, it has no survival benefits. But 95% of that subgroup in Singapore still gets dialysis. It's incredibly expensive and it's not very nice either. It's not comfortable and yet they do it. So lots of challenges, and a lot of it, as I said, is caregiver driven. So, problematic, right? Now, one thing you might hope is that physicians would intervene on behalf of patients. Right? So maybe the clinicians themselves can solve this problem and make sure patients aren't overtreated and get appropriate care, right? Well, maybe. So we looked at this, and of course, we use surveys and vignettes and everything, so it's not a perfect system. But let me show you the results of a study that we published trying to assess this question. So again, I want you guys to pretend that this time, I'll put you in the hat of a clinician, and you're treating a particular patient, Mr. Tan, who has the following scenario. Mr. Tan here, 75 years old, advanced serious illness, no chance of cure. Without treatment, Mr. Tan will live 6 months. With treatment, you can get him up to 18 months with a 5% chance of 5 years. Side effects include moderate pain, nausea, fatigue, limited mobility. Treatment is $55,000. Patient has no insurance or subsidy. So I want you guys to think in your mind, if you were the clinician, would you recommend life-extending treatment, or would you not recommend life-extending treatment? Take 15 seconds. I'm going to ask you your answers in a second. Okay. Raise your hand if you would recommend life-extending treatment for Mr. Tan. I see 2, 3. All right, raise your hand if you would not. Let's see. More. Some of you are just not voters. Okay. All right, how about this? Would any of you recommend treatment if Mr. Tan had cognitive impairment? You would have the same answer?
No.
Or you would not, in this case?
Different.
Different answer, okay.
With the treatment...
Same treatment, same outcomes.
So you wouldn't affect the cognitive...
No, wouldn't affect it.
I would not.
Would anybody recommend treatment for a cognitively impaired Mr. Tan? So, by the way, this question matters because, as you know, dementia, cognitive impairment is on the rise, and people talk quite a bit about rising healthcare costs associated with dementia in the U.S. and other places. And certainly there are increased costs associated with that, but there's actually a large cost offset. Because the reality is, if you have a loved one with dementia, you don't get chemotherapy, you don't get dialysis, and you're not going to spend a lot of money on life-extending care. So people with dementia die very differently. Right? Now, we actually have a cohort study starting in Singapore to quantify some of this, but it certainly isn't surprising because people are just far less likely to pursue life-aggressive or life-extending or expensive treatment for people with cognitive impairment. But, okay, so getting back to Mr. Tan. So before I show you what our doctors told us, let me just tell you a couple other facts. So in a different study, we asked patients scenarios like I just showed you, and we said, would you choose palliative care? Would you choose life-extending treatment? And then we said, okay, what would you switch if your doctor recommended the alternative? The idea here was to try to get a sense of how important is the doctor's recommendation in your decision making. Would you switch your decision based on what the doctor recommends? And in fact, what we found was that, and this actually was dialysis patients, but it extends to just about any patient, I would guess. Roughly half of patients and 68% of caregivers said they would switch away from their preferred choice if the doctor said the opposite. And for things like chemotherapy versus palliative care or dialysis versus palliative, these are major decisions, right? So this is big, and yet more than half are deferring to the clinician. And in fact, for caregivers, it's almost 3/4, right? So I raise this point just to tell you that clinicians, they're incredibly powerful, right? Their judgment and their decision-making, whatever they recommend to the patient is highly likely to influence their decision. And I would go further to say that most of these decisions are non-clinical in nature. Right? Whether you pursue life-extending care or pursue palliative care, those are very personal decisions. I'm not sure what the clinician really has to offer in that sense. Certainly they can educate the patients about the side effects and maybe the costs, although it's unlikely they would do that, or the benefits. But the reality is, regardless of all that, whatever the clinician says, many, many patients will do it. Now, the problem is even worse when I show you the results getting back to Mr. Tan. It turned out we asked a bunch of physicians, and the answers was almost a coin toss. So 43% of physicians said, yeah, I would recommend life-extending care. The rest of them said I wouldn't, right? Unless Mr. Tan had a cognitive impairment, which just about everybody was like, yeah, don't do anything, right? But the point is, if you look at the data, and I don't think this is so unique to Mr. Tan, there's a lot of disagreement in how to treat these patients. A lot of disagreement on should you give these older patients dialysis, should you give them chemotherapy. Some physicians will say they would, some physicians say they won't. Now, it gets even worse when you realize that clinicians have lots of competing objectives. If they're for-profit, they'll make a lot of money by providing this treatment. They're also in a broader healthcare system, which is encouraging them to make decisions for cost containment. So physicians aren't the most objective either. Caregivers, same thing, right? So everybody's vested, right? Now, let me just show you results. So we had a lot of Mr. Tans in our study, and regardless, what we found was that, basically if the patient was older, physicians were less likely. If the survival was better, more likely, but costs certainly played into their decision. So basically, things matter. So it's not totally ad hoc, but certainly even in our most, even here, for example, you still have a fair number of clinicians who are acting differently. So here's our Mr. Tan, 43%. You can see there's a lot of randomness throughout, unless the patient has cognitive impairment, in which case there's a lot of agreement that says, hey, we shouldn't try to extend life for people with life-limiting illnesses, for good or bad, right? So to me, this too suggests that clinicians are not necessarily the ones that we should be looking for to answer our decisions about whether or not we should get life-extending treatment, right? A lot of noise in the data, a lot of variation in their recommendations. Okay, so what does that suggest then? Basically, what it suggests to me is that when you ask people like us, generally healthier people, you ask patients themselves who are prone to biases from things that probably shouldn't matter. You talk to clinicians, they're vested in lots of things, and it's not clear whether or not they're in the best position to make recommendations for things that are non-clinical. And you talk to caregivers, none of them are particularly good at being advocates for patients. So what is the implication? Well, to me, we don't have the right model. I think when it comes to end-of-life care, we really need to find somebody who I think isn't so vested in the system or vested in the patient, somebody who's more objective, who can provide better guidance on how to help somebody through their end-of-life experience. Right? I think that's needed, and I think there's a lot of value in that, both for the patient's perspective as well as for the health system perspective. I think we would get better outcomes, people having a better end-of-life experience, and probably lower costs, right, if we were able to do these things well. Now, I also think in doing these studies in cancer and in dialysis, patients need help. And that decision or that discussion that they have with the physician when they've just received probably some pretty devastating news and they have lots of angst and nervousness, and they have a very hard time separating what they believe from what they would like to believe or hope. They're not well positioned to make informed decisions. And I think in the US, and even more so in Singapore, there's a real push for patient autonomy, to try to say, we want patients to make these decisions. And my point is, well, yeah, that sounds great, but when you really start to look at the way patients make decisions, it's not so great, right? So we need something better. Now, I think patient decision aids, we need lots of other things can help, but I also think even that is not going to go all the way there. We need more. Now, I talked earlier, I said, well, what is the sort of, are patients making right decisions? I think the reality is there is no right decision in these cases. I think when, for other healthcare matters, I think there really is. But I think for these things, it's, you just make a decision. And I think the key is not whether it's right or wrong, and it's not even whether you stick with it. I think people often, at the end of life, think somebody changing their mind means failure. I don't think that's true. I think changing your mind is great. A lot of people will get dialysis, for example, and say, this is awful, and then they'll stop. Or they'll put dialysis off, and then they'll start, change their mind. I think that's fine, right? Chemotherapy, you try it, you don't like it. I mean, the reality is all of these patients will die. What we really want is for patients to die without regret, right? That they feel good about the decisions that they make, even if they change those decisions later. And I think that's the key.
About the avoiding regret piece, I don't know if you've read, there's like a researcher at Memorial Sloan Kettering who does research on meaning therapy for cancer patients, and that's kind of a way to avoid regret. I wonder, have there been any initiatives like that in Singapore where they're, instead of trying to make them choose the right decision, they sort of accept that?
So I don't know exactly what you're describing. I mean, there's not a lot of research going on in these issues in Singapore, to be honest. In fact, there's not a single palliative care clinician scientist in the country. I am the best health economist in Singapore because I'm the only health economist in Singapore. It's a small place. We don't have, so we're trying to build research capacity, and so there's a big need for these types of things, but we're really in our infancy, right? There's a lot of fantastic clinicians, but unfortunately not a lot of clinician scientists. So, to me, these are the things, and as I said, changing your mind is okay as long as you feel good about it, right? So, any questions about this? Go ahead.
So how do you help them, or how do you design a model that sort of helps avoid regret?
Right. So that's the big question. So as I said, I really believe we need to find somebody whose job it is to take people through this process, and I don't think it's a clinician. Right. So oftentimes, the way things tend to work in Singapore, and I think a lot in the U.S., is you have a clinician who's trying to extend your life, an oncologist or a nephrologist, and this goes on and on and on, and then at some point they give up, they pass you off to a palliative care clinician who tries to manage your pain, and then you die. Right now in Singapore, it turns out that transition to the palliative care doctor, from that period until death, is 30 days. Very late, right? It should be happening much, much earlier in the process, but it doesn't, right? So I think we need a new model of care where we have somebody in here who's really an advocate for the patient and helping them through this process far beyond this 30-day period, right? And we need lots more of these types of decision aids and education so that we can educate patients to make better choices.
4 quick things, do it and what you will. I used to run a group down at the Duke-NUS School where we brought together long-term care, assisted living, palliative care, hospice care, FUC, twice a year. So we brought in Atul Gawanda and his work, which, he ran a clinical trial and he had people, patients. So some of this sounds consistent with that, although he's not coming to the same conclusion you are. He's trying to improve the 5 questions of the decision-making of the doctor. So I'm curious about that. There's a lot of information about so-called shared decision-making, but it's not working with care at the end of life that seems to move in a different direction. This finding or this suggestion is similar to conflict of interest finding, I'm blocking her name, who's at Georgetown, where the physician has a self-interest. It's it's something that they get royalties from or whatever,
Yeah.
that inserting someone in between is a better way to handle that. And then finally, dialysis care, as you know, in Singapore is odd, the way it's funded and the way it's done. And I'm just wondering how you're accounting for that. So pick anyone, it's a Chinese menu.
Yeah. So what I would say, I'm certainly familiar with Atul Gawande's work, and I think we're actually saying very similar things, right, in terms of what we think patients should be getting at the end of life. So I think so I will tell you, to be perfectly honest, his book changed my views on some of this stuff, because as an economist, it sort of sounds obvious that it should be patient preferences and patient autonomy, and that you should throw it back on the patient. They're the ones who have to do these things. It shouldn't be the doctor. It shouldn't even be shared. But I think his book is quite convincing that patients just aren't going to get it right. And then our work, to me, which quantifies some of the reasons for this and others, it just makes total sense that patients just, patient autonomy sounds great, but it's just not going to work, right? They just aren't able to make these very complex decisions. And he says exactly the same thing. Now, I think with respect to dialysis, Singapore is unique in lots of different ways. And so I think a lot of what you see in terms of outcomes is driven by some of the peculiarities in the system and the financing models of the system. So I certainly think, and that's probably not true of just Singapore, of many countries, but really, as I said in the beginning, the financing models really drive behavior. Now, one of the things in Singapore is the government is still very heavy-handed and believes that they can manipulate the system. And so although I argue with them all the time that just get the funding right and back off, they just can't do that. So the government, everybody, all of the hospitals in Singapore are largely government-owned through these holding companies. So they come up with care pathways, they come up with all of these things, and they're just heavily involved in how things go, and less interested in letting markets solve problems. That's one of the realities, and I'm certainly trying to encourage them to do demonstration projects and pilot projects, but so far I haven't had success. Although, that said, I will say one of the reasons I love being in Singapore is because when I talk to the government, I'm talking to one level below the Minister of Health. Whereas in the US, when I talk to the government, I'm talking to an RA who's 30 levels below a division director. So your ability to influence policy for somebody like me is much greater in a little country who really cares about having good outcomes and costs and is very responsive and much less driven by the politics of the day. So in a one-party system, things happen quickly, good or bad. So let me move on a little bit just to give you a couple more minutes of the other stuff going on within our center. So I mentioned preferences. I spoke a lot about it. We have these other three areas. I touched on a couple cohort studies. So we have a large one on cancer patients that we've already recruited 500 or so, and we follow these guys every 3 months until death. And here, the reality, the goal for this is to just try to quantify how poorly the current environment is for these patients, how costly it is, and to try to convince the government of a new way. They really need to do things differently. And we're getting, as I said, lots of interesting data about perceptions, quality of care, quality of life, continuity of care, costs, and we also survey caregivers, and we survey the caregivers after the patient's passed to look at, how are they recovering, bereavement, those types of things. So it's a really neat study, and we're going to get lots of data out of it. And in fact, we started another one on heart failure patients. And in fact, if you look at end of life, it's almost always cancer patients. To some extent, cancer is easy because the trajectories are sort of well known. Heart failure patients tend to go up and down, up and down, up and down, and then they die. Right? So it's much different. And they tend not to get any palliative care. So we have a study looking at heart failure patients to try to look at some of these things there as well. And as I mentioned earlier, we have another one looking at dementia patients that's just about to get going. We're just waiting for a letter of award. And really the goal here is to see how do patients with dementia or cognitive impairment die differently than other patients. And what are the cost implications for that? And what can be done to improve their end-of-life experience. Now, we also do quite a few intervention studies designed specifically to test strategies aimed at improving care. Here's one by one of our psychologists looking at psychosocial intervention. So we have a psychologist on staff. Actually did some of her training here at Duke and then down in Texas, but she's a Malaysian Chinese. She's been with us for a couple years. She's really great. So she sees patients at the cancer center and runs psychosocial interventions and grants in that area. We do have a trial looking at dialysis is going to get going soon, and here the idea is really to try some of those patient decision aids, video vignettes, to see if we can't get people to make different choices by giving them better access to information. This is a pilot study, about 150,000 US. If it works well, we'll do a much bigger trial. Right? A different end-of-life model aimed really at trying to get palliative care clinicians involved in the end-of-life experience earlier. This is another one. This is a very junior palliative care clinician, sort of the first one in Singapore. She might be the first real palliative care clinician scientist. She just finished her training at Harvard and is now back in Singapore. She's starting a study looking at a special model or a different model of palliative care. And in fact, we have a fairly large randomized trial looking at the role of advanced care planning. Advanced care planning sounds great. Patients can say what they would like to have happen when they can't make decisions for themselves. They write it all down, it gets into the chart, everything sounds wonderful, except it turns out it doesn't work. Right? And it's been shown not to work in a lot of countries. Singapore's invested a lot of money in it. We are testing it in Singapore, and we're generally finding it also doesn't work. And we have some reasons why, but basically we think this is going to be a really important study locally. Now, I mentioned earlier that we really want to have an impact in the region. It's difficult because our funding model doesn't allow it, but I've managed to squirrel away some money, and we're doing a survey in lots of different countries in the region, and it's really just aimed at quantifying among cancer patients how they die, right? And so we have many countries included, and we're getting more every month or so. 1 or 2 countries will come onto our list. And the goal here is really to work with these guys, find some relevant partners, and then to do more studies with these guys, hopefully through external grants. So we're trying to build research collaborations in the region that we can ultimately then do more of our cohort and intervention type studies. So education, I'll just talk quickly. So most of our education is blended learning, and in fact, my education director, who was with me for several years in Singapore, M.H.A, just moved to Chapel Hill, so I need a new one, but she probably could talk about this stuff better than I can. But basically, we try to deliver blended learning programs, classroom-based, internet-based learning to generalists largely. We decided that the clinicians, they get enough in their training, so we focus on sort of non-clinicians who interact with patients. And if you look at our courses, most of them target nurses, social workers, pharmacists, or others that we think are going to have a lot of interactions with these patients and have the real ability to make a difference, but right now have had very little training or experience. Actually, there's a couple other things, but let me stop there and people can ask some questions. But basically, I think what we're doing is really important. I think we're learning a lot. We're publishing lots of papers, lots of opportunities for people to get involved in our research. So I'm very proud and excited about what we do, and I think there's lots of potentials to really do more and hopefully more collaborations with our partners here. Okay, so let me stop there. Anything?
So I want to go back to the choice experiments for a minute. I mean, I thought that was fascinating work, and you talked about one implication was maybe promoting better decision aids for patients. But what are the implications for clinician behavior? Are there any opportunities there to translate some of those findings into better clinical decision making?
Yeah, so great question. So the truth is, we know, like for our dialysis, the problem is the doctors. The doctors it's just a lot easier for a doctor to put a patient on dialysis than to have a really difficult conversation about why your loved one is not a good candidate. So part of this is trying to back into proving to clinicians that they're the problem so we can then have a conversation with them about how do we do things differently. Clinicians are a tough bunch. It's tough to get their time for anything. It's tough to convince them that they're not perfect. And so this is, this is a challenging area, but I think you have to come at it with evidence. right? And so we have to gather this evidence. We have to be able to bring them something to say, hey, here's the problem. We've looked at all of these other things. Nothing else adds up. Let's talk about what you do. And we're starting to have, so when we have these discussions, it's amazing because we have nephrologists on our study, like our dialysis, and they start to open up and they say, well, sure, if it's like somebody I know, I always say dialysis. But if it's somebody I don't know, maybe I would have that comment. So it's tricky, but it's a great comment and it's a tough area. Other questions?
I have a question. It's kind of in regards to that study as well. Some of the information that we looked at are very culturally based. So the caregiver relationship, I know is kind of something that's unique to Asian cultures. And then you had said that a likely intervention would be to look at ways to take that end of life decision care out of the physicians and away from the caregivers. Has there been any work, have you studied or believe that that's been integrated within cultural models?
Well, by the way, if you have to go, I know people have classes and other things, so please go. But you're absolutely right. There are certainly cultural dimensions to this. But what the biggest driver of change in Singapore, to be honest, is the legal system. Because what happened recently is a clinician was censored and barred from practicing for 6 months for doing exactly what all the clinicians do, talking to the caregiver and not the patient and not getting consent. So I think consent and legal issues are, sort of moving into a Western style of medicine has been having a large influence, good or bad, on practice styles. But by the way, I think this notion that people in the West are so different from people in the East, it was true a generation ago, and 2 and 3 generations. If you look at young people in Asia, I think those differences are going away very fast. And by young, I mean like people in their 40s. That's again. So let me stop. If people have questions, I'm happy to stick around, but I know people have lots going on. Again, thank you for coming. I appreciate it.
Thank you.